Good afternoon and welcome everyone to today's edition of Black Health Trust. We are so happy that you chose to spend this time with us. We're going to have a discussion today about a very important topic, one that we all should have knowledge of so that we can do what we can do to either prevent it or identify it when it is at a point where it can still be treated. So without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara A. Stevens, and thank you for all my co-moderators. We do have a very important topic. We're also coming up with the 250th anniversary of the founding of our company. Dr. Walks, I sent you something in your email. I wonder if you could summarize it in a couple of statements real quick.
I will look for my email. So we're starting off with a surprise technology quiz
No,
to see if I can open my email. Okay.
you can just
You
summarize it.
sent me Frederick Douglass. Is that what you sent me?
Yes.
What is the slave? What to the slave is the 4th of July? So if you want me to summarize this in just a few statements,
Yes.
I can just go right to the conclusion of this. The excerpt from Frederick Douglass is, what to the American slave is your 4th of July? The answer, a day that reveals to him more than all other days in the year the gross injustice and cruelty to which he is the constant victim. Now, Frederick Douglass had several key themes in that presentation: liberty and hypocrisy, the Declaration of Independence, the Constitution as a potential anti-slave document, and hope that the United States would ultimately fulfill its founding principles. In the conclusion, Frederick Douglass concluded with hope rather than despair, stating, quotes, "I do not despair of this country," end quotes. His speech remains one of the most influential commentaries on freedom, justice, and equality in American history. So he decided to conclude with hope rather than despair. That's a quick summary, Dr. Maxey.
Very good. Excellent. Excellent. And as you eat your barbecue and do your firecrackers in the next few days, think of Frederick Douglass. It's very true. Let's go to the slide, Simon. And I'm going to need all of everybody's assistance on this. So our topic today is how to understand colon health. Next slide. So why this organ matters. The colon absorbs water and forms stool, your bowel movements, gets rid of waste. Next slide. So how common is colon cancer? It's the third most commonly diagnosed cancer, and excluding the skin. It has a lifetime risk. Dr. Neighbor, can you help me read this?
There's a lifetime risk of around 1 in 24 men getting colon cancer and around 1 in 26 women getting colon cancer. More than 150,000 new U.S. cases are identified annually.
Next slide, Dr. Walks.
Why it matters. The second leading cause of cancer death, I can't see the end of the slide. Second leading cause of cancer death when men and women
are included.
Are included. Okay. And then early detection can prevent many cancers by removing precancerous, and I'm guessing that would be polyps.
Yes. Next slide. Is that Heinz?
Who is
Tick.
most at risk? Those over the age of 45, those with a family history of colon cancer, those who have certain hereditary syndromes, inflammatory bowel disease.
Next slide. You can take this one. That was a little short.
And so the warning signs, the warning signs can be rectal bleeding, persistent bowel changes. One of the classic ones is that your stools get very, very thin, unexplained anemia, abdominal pain, weight loss, fatigue.
Okay, next slide. That's Lawson here.
Dr. Lawson is here. He needs to be unmuted.
That's Barbara Neighbor. See, we're going to go to
Screening options, colonoscopy every 10 years for people who have an average risk, a fecal occult test. I think that's what a FIT is.
it is, but it's called fecal immunoglobulin test.
Oh, annually, and a DNA FIT test every 3 years. Abnormal stool tests require colonoscopy. I just want to emphasize that colonoscopy every 10 years is for those at average risk. There are different recommendations for those who have a more than average risk.
And so who's at high risk? People who are Black, people who have family history, right?
Correct.
Okay. Let's go
Can I
to-
also just add too that the FIT test and the FIT tests are not indefinitely, because you're after a certain period of time, I believe it is after 10 years, you're still recommended to get a colonoscopy.
Yeah, that's the gold standard.
Yeah. Some people think that's we can just leave it there, but that's not the intent.
A lot of people are scared of colonoscopy. We'll talk about it as we go on. Next slide. Is that Lawson?
Yeah, Jim. It's like,
This is the-
what is FIT? FIT is, as we said, the fecal immunochemical test. And there's home stool test that detects hidden blood. It's used to screen for colorectal cancer in average risk, as the point that was made, average risk adults. No bowel preparation or dietary restrictions are usually required.
Okay, next slide. Who's next up? Is it that's a neighbor Stephen that walks?
Dr. Walks.
That's a walks?
Right. Advantages and limitations related to the FIT test. There are advantages. It's a simple, non-invasive, performed at home, typically repeated every year. A positive FIT requires a diagnostic colonoscopy. Colonoscopy, as we stated earlier, remains the gold standard because it can detect and remove precancerous polyps.
So why do so many of us hesitate to get a colonoscopy?
I think
Because
it's
you're going the
because
wrong way on a one-way street, Dr. Maxey.
no, and they think that they don't know how it's done, and so they think they're going to be awake during a very unpleasant experience. Now, to me, the prep for the colonoscopy is the worst part because now that they're using propofol for the anesthesia to have the procedure, that's one of the best sleeps I ever had was with propofol. And you have
They use
absolutely
anesthesia
no,
for colonoscopy now?
yes.
Last one I did that didn't have anesthesia.
And
So-
And that was last year.
No, so let me just emphasize to Dr. Lawson's point. A lot of people have memories of colonoscopies with a rigid phlegmoid
Sigmoidoscopy.
sigmoidoscopy colonoscopies are not the same as your grandfather's colonoscopy. And I think it's important for folks to know that they do use anesthesia now, and it's a very different procedure because it used to be really, really uncomfortable for a lot of people.
I
I
hate
would
to
also
say
say
it,
too,
Dr. Walks, hate to say it, but it's not universal, even in especially in this area.
Mm,
So
yeah,
wow.
Because
I
yeah,
would also add to that the prep has changed. Like it used to be you only had that whole gallon of Go Lightly that you
right,
had to
that's right.
drink. And for a lot of people, they found that very intolerable. But there are multiple different options that they have available to do the prep now. So it doesn't have to be as onerous as it has been in the past either.
yeah, my recollection when I had mine, he told me to count down from 10 to 1. And I started counting. I said 10, 9. How long is it going to take? He says, I've been waiting on you to wake up. We've been done a half hour. Next time.
I just want to know when I had mine and said, "Oh, take a look at that. Could you see that? It looks pretty good, doesn't it?"
Mm.
Can I also add too that there are risks, right? People do get they're small, but you can get bowel perforations from the removals of some of the polyps and those types of things. So that is another reason why people are also afraid of colonoscopies because they might know somebody who had something who had a bad outcome. And then for a lot of people and for other people that they complain about is that feeling afterwards, because they put a lot of air into your colon to blow it up so that then they can see. And people also complain about discomfort as the air leaves, and it can be embarrassing to be passing a lot of gas, right? It just is, and that's how it's gonna be when the air comes out. So there are some things that people need to be aware of. It's not necessarily a reason not to do it, but there are some things that we legitimately need to be aware of.
And so, to that point, when you speak with the provider who is going to do your procedure, there's some questions you need to ask them before you decide that that's the provider for you. You need to ask them, how long have they been doing this procedure? You ask them, how do they do the procedure? Not that you want a blow by blow, minute by minute description, but to what Dr. Hines was speaking to, you want to know about the air and all and they will tell you if they are um, appropriately counseling you about the complications. But when they tell you about the complications, or even if they don't tell you about the complications, you bring up the complication. You ask them, how many complications have they had? And the final question is, how many of these procedures have you personally done?
Mhm.
But one thing I want to say behind that, even though she's very right, there's absolutely no medical procedure, including getting your blood drawn, that doesn't have a potential side effect. You can drink water and choke. So I don't want to scare people. They need to have a colonoscopy.
Well, we need to state very, very clearly that all of the concerns that we're raising, the concerns about the discomfort, the concerns about the gas, all the concerns about even minor perforation, pale in comparison to the risk to your life, because colon cancer will kill. I'm sure we will get into that today, but none of the things that we mentioned are 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 as life-threatening as actually having colon cancer.
And I also want to like to note that we did actually a survey of a group of people and found that the fear was not actually the procedure itself. It was the thought of the procedure. Those, like several of us who've had procedures without anesthesia or anything, didn't have a bad time and no problem. Whereas some people who even had anesthesia, frightened to death because of the concept of having the procedure itself, because of unfamiliarity of how the human body works, as well as what actually goes on in the procedure.
Okay.
So we're just not going to the place that you went, Dr. Lawson.
Who's next? Take the next 2 slides. Whose turn is it?
Stages in survival. So localized disease has an excellent 5-year survival, and survival rates decrease with regional and distant spread. Early detection is best.
Take the next one since I was so short.
So a healthy lifestyle. So healthy weight, regular exercise, having a diet that includes fruits and vegetables, whole grains, less processed foods and red meat, avoiding tobacco, limiting alcohol, are all healthy lifestyle things that you can do to reduce your risk of colon cancer.
You mean we're back to lifestyle again? I thought we did that last
Look
2
at
months.
that. Look at that.
Always.
Next slide. That's Lawson.
African American communities, higher burden of disease highlights importance of timely screening and access to care. I don't want to critique race at this point, but there are a number of providers who do not want the risk of anesthesia, and so they try to avoid such things.
Wow.
Yeah. Go ahead. That's Neighbor Stevens.
Next, healthy colon habits: eat more fiber, exercise regularly, avoid smoking, limit processed meats, and know your family history.
So why do we keep talking about this healthy eating stuff? And seems like we're overkilling that, you think?
Yep. I'd like to hear what some of our colleagues would have to say. That there's been a couple of studies recently that's sort of downplaying the importance of fiber. And I'm just wondering what some of your thoughts were.
I've always thought that fiber was one of the most important things because it allows you to develop the bulk and allows you to get the fluid into your gut to excrete your stool. And I haven't seen anything that's worthwhile to convince me otherwise yet on that. Dr. Hines, what about you?
Yeah, Dr. Maxey, I think that's an excellent point. I just want to mention one other point. It says limit processed meats. Some of the folks in my area limit processed meat by eating what? Raw meat. And there has been some documented cases, especially recently, of folks who have suffered the consequences of eating, to put it nicely, larva-infected meat.
Okay, let's go to the next
So
slide.
so we have to just not do some of the things that Dr. Lawson does. We don't want to go to his colonoscopy place, and we don't want to have dinner with the people that he has dinner with that eat the raw larva infected meat. I mean, so because all of that is part of lifestyle, right? Knowing where to go to get the right procedures, knowing where to go to get the right kind of food. And one thing I'll mention, Dr. Maxey, when you talked about fiber, there are a lot of reasons to have good, easy bowel movements, not the least of which is the straining and the hemorrhoids and all the other things that can come up. So yeah, lifestyle continues to be important.
And
And
people
I
stroke.
was also just gonna say too with the original question about fiber and on the simplest way I think to kind of look at that link is fiber helps keep things moving, right? So if you think about being constipated or slowing down the transit of the things that your body is trying to eliminate, right? Then there is it makes sense that there would be increased inflammation, increased chance for things being in your body longer than what is desirable. So that's kind of how I think about it. And then the other thing that fiber also does, in addition to keep things moving, is it also, as we now know too, the importance of healthy bacteria in your gut. And fiber is also really important in helping keep that balance. So I think there are some direct and indirect roles, as well as the role that it can play in your overall metabolic health. So it can certainly play a role in reducing your cancer risk because it helps you keep your other issues under control too.
Amen.
Very much. Dr. David Stevens, I think it's you.
Colonoscopy is the most accurate screening test. It detects and removes polyps, usually every 10 years if it's normal, and as we've been discussing, requires bowel preparation and sedation.
Take the next slide too, if you would.
Side-by-side comparison. Colonoscopy has the highest accuracy and it prevents cancer because when those polyps are removed, if they are precancerous and they're removed, then you don't have to worry about that polyp developing full-blown cancer. Blood tests are convenient. They are good for average risk adults who might otherwise skip screening.
Take the next slide too.
Who needs colonoscopy? Family history, previous polyps, inflammatory bowel disease, or symptoms of rectal bleeding, anemia, or bowel habit changes. Let me just comment on the rectal bleeding. When we say rectal bleeding, we're talking about all forms. There can be rectal bleeding where when you wipe, you see bright red blood. There can be rectal bleeding when you see tarry black stools or bright red blood on the surface of the stool. But any form of rectal bleeding is a warning sign that needs to be followed up.
Could I
I
just
just
piggyback
want
on that too and just add two things can be true? You can have a history of hemorrhoids and also still have, something more serious like colon cancer that needs to be checked out. You can have a history of things that have caused rectal bleeding in the past that may have been benign. And then new or different bleeding could also be a sign that there is something else going on.
I just want to note that I had a patient, actually, I was a medical student who presented with rectal bleeding and bipolar disorder. His doctor had told him that rectal bleeding was just something that happens when you get old. We went in, found out he had colon cancer, and removing the cancer treated, in fact, cured his bipolar disorder because of a lot of these cancers actually have endocrine products that can lead to psychosis.
Good point. Good point. That's David Stevens.
Healthy healthy lifestyle. Eat fiber-rich foods, exercise, avoid tobacco, limit alcohol, maintain a healthy weight, and not on here, but I will add plenty of fluids, non-alcohol fluids.
Excellent. Dr. Walks.
Multi-cancer early detection, MCED. Blood tests aim to detect signals from many cancers. Examples: Galleri and other developing platforms. Not yet recommended as a replacement for guideline-based screening. And there are several references.
I'm so glad you brought this up because I was going to bring it up, Dr. Maxey. I should have known you were going to bring it up. So I've noticed lately, real recently, there has been an onslaught of advertising for blood tests for multi-cancer screening. And I wanted us to talk about that, or at least mention that this is now available, but you need to know, you need to ask. Let me just say it that way. You need to ask if it is covered by your insurance. It is not currently covered by Medicare. And the concern is it's promising, but it is not the standard of care. So if your provider recommends to you, or you see this ad on TV and say, oh, wow, I can kill 50, because it's the current one that's being advertised screens for 50 different cancers. Wow, I can just knock it out the ballpark and see if I got any of these cancers. And you don't have to have the cancer totally developed. It picks up the genomic and proteonic signals that these masses, malignancies are in the process of forming. It's a great concept. I hope it gets worked out, the bugs get worked out of it. But beware, uh, and have a conversation with whoever it is that's suggesting to you that you get it, or before you go trotting off somewhere and think you're going to take care of it yourself.
Very
Dr.
good.
Maxey, I want to bring up another point that seems less of an issue now, but a decade ago, they were really pushing using MRI to screen for colon cancer. And there were a bunch of groups came up with varying kind of imaging techniques that claimed that they got almost as good results as colonoscopy. Fortunately, that seems to have been fallen by the wayside, but that's still something that some groups have tried to offer.
Okay, so right now we're still at the place where we know that the gold standard is what?
Colonoscopy.
Colonoscopy.
With anesthesia.
Yes.
Next slide. Dr. Hines, who's up?
What blood tests can and cannot do? They can increase screening participation. They can detect some cancers early. What they cannot do, they are not a replacement for the gold standard tests that we know about, things like mammograms, colonoscopy, pap smears, or low-dose CT scans. They cannot diagnose cancer by themselves.
Next slide.
And they're not cheap.
That's right.
These tests are almost $900.
And remember too, whatever result you get, especially as it relates to negative results, I am not clear on this, but this is for the moment in time, correct?
Correct.
Right. So it's not like it's a one and done, woo! Like, and then I can go on with my, go on, right?
Dr. Lawson, I think you're next.
Dr. Lawson?
Who should consider blood-based?
Wait, is that?
I think we missed a slide.
Go back.
Oh, yeah.
There we go.
Yeah. I'm going to do this one.
Yes.
Our standard of blood tumor markers: PSA, prostate; AFP, liver cancer surveillance in selected patients; CA 125, ovarian cancer evaluation; CEA, follow-up of colorectal cancer; and CA 19-9, pancreatic-biliary monitoring. These are generally not recommended as screening tests for the general population.
Well, we do PSA. Every man over 40 in my office gets a PSA. And that's something we look at and see what the change is over the months or years. That's very important, what the slope of that line is. So, and some of these others we should do periodically anyway. Let's go to the next slide. That's Neighbor-Siemens.
Who should consider blood-based screening? Average risk adults who decline colonoscopy or stool tests. Discuss this issue with your healthcare provider. High-risk individuals often still need colonoscopy or other standard tests.
Next slide, that's Walks.
Take-home messages. Screening saves lives. Screening saves lives. Blood tests are an important advance. Traditional screening remains essential. Ask your physician which test is right for you. And I'll just add that point number 4. We've talked on Black Health Trust for years about the importance of having your local practitioner, physician, someone who knows your medical history and who is looking out for you, who will make sure you're getting annual screenings annually. And as Dr. Lawson continues to point out, it's very difficult in some communities to have that doctor or that practitioner that takes care of you. But especially because health plans change and this doctor's covered, that doctor is not. But having someone who knows your medical history and who is able to tell you what test is right for you and when you need the next test is just so important.
Next slide. I think it's the last slide. One more slide, I think.
This is the references.
I think it's the last one. But I want to bring up the point that we spoke briefly about last week. If you have colon cancer and require to be resected, and I spoke to Dr. Marietta Borum about this, you want to make sure that if you have nodes that are positive, that it is a standard procedure that you receive a larger therapy post-op to make sure there are no micro migrations of tumorous tissue. So we spoke about the screening and about the polyps, but we haven't dealt with the real surgery and the real treatment. So colon cancer is something that can ruin the rest of your day, the rest of your life. It's very important to follow the directions of your provider. In order to do that, you need to have a provider that you have confidence in and belief in and have that relationship. And as Dr. Neighbor Stevens says, it's good to have a good relationship and be sure to ask the questions to put your mind at ease to be able to follow directions. There's no sense in having a major operation and then die a few months later from not having followed his directions. Any other comments? Any information in the chat, Dr. Neighbor Stevens?
No questions.
Yeah,
I had a comment, Dr. Maxey, on what you just talked about with respect to the follow-up. I talked with someone who went to get their chemotherapy medicine and then tried to get it from the local pharmacy. The local pharmacy said, no, it has to be a specialized pharmacy. And then the specialized pharmacy said, no, I think the doctor didn't prescribe the correct amount of the medicine, prescribed a significantly higher dose of the medicine. And so the pharmacist reached back out to the doctor and the doctor changed the dosage on the medicine. I say all of that to say that Dr. Gibson, who is on Black Health Trust frequently and is a pharmacist and tells us about the importance of knowing your pharmacist and having a conversation with your pharmacist. I told a story a long time ago about my pharmacist asking me, why is your doctor prescribing this cholesterol medicine for you? You're paying $300. There's one here that costs $30. Ask your doctor if there's a difference. The end of the story is no, there was no difference. And I asked my doctor, he said, well, that's the one I always prescribe. They both work. So knowing your pharmacist at all times, trying to have a conversation with your pharmacist, making sure your pharmacist is part of your treatment team is just a reasonable. These people go to school for a long time and they're really smart. And there's no reason not to have your pharmacist be aware of what's going on with you so that your pharmacist and your doctor and all the other people can be part of your treatment team.
Now, in today's medicine, a lot of us do our prescribing by electronic medical records. So you really don't come in touch with the pharmacist many times. That's something you're bringing up we need to do more of.
Yep.
Like, I haven't seen a pharmacist in years until they come to my office to see me. But it's something that modern medicine tries to take all these shortcuts. So be careful, and be conscious of who your healthcare providers are. And I do agree that pharmacists ought to be a part of that team.
So we do
Yeah.
have a question, a good question from Ms. Hall. And I don't know the answer to it, but the question is there an upper limit to when you no longer have to get tests? And that is a very good question. I know that as far as breast cancer is concerned, that there is an upper limit to when it is recommended that you continue getting annual mammograms. But my OBGYN told me that if her patient asks her to get a mammogram, she's going to get it, even if they are above that cutoff point. Remember that for colon cancer, the incidence goes up after 45. So, does anyone know what the recommended? Of course you do, Dr. Hines.
Go ahead, Dr. Hines.
So, in general, after 70, once you get to 75, then you start having some individualized discussions on your overall health status, life expectancy, things that were in your prior colon cancer screenings, that type of thing. In general, colon cancer usually has about a 10-year lead time between when it theoretically starts and when it's really causing bad problems for you. So the thought is basically, if you for other reasons have a life expectancy that is less than 10 years, then you may not need to continue to get colon cancer screenings, assuming that everything's been just fine. But that also means that if you are 80 and robust and those types of things, then you might want to continue to get your colon cancer screenings. So that's the overall recommendation. 75 is when individualized conversations start.
So let me.
Polyps are something that the follow-up is if there have been polyps. Polyps put you in that category of higher risk.
So let me go to Dr. Hines again and ask a question as if she's my physician. So my oldest patient in my practice right now that I just did a note on 2 days ago is a friend of my mother's, and she is now 109 years old. And the only problem she has medically is high blood pressure. In my family, our life expectancy is usually about 95 to 99 years old. I'm currently about 85 and a half. You think I should get a colonoscopy? It's my time this year.
So in general, I would say your personal doctor knows all of your details, but things that you're going to have to consider, right? Because we talked about anesthesia and those types of things. Are there other, because I suspect sometimes you might have other health issues going on, right? We can be robust people, but might have other health issues. So then the question's going to be, do the risks of the procedure outweigh the potential likelihood of benefit? And that's where all the details would kind of come into play. Overall, if everything else was gravy and you wanted to have the procedure, if you said, I want to have another colonoscopy, that would make me feel, good about the status of my health, and I want to stay up on all my screenings, that type of thing, and there were no reasons not to, yes.
Dr. Walks, there's a church song saying, trying to reach 100, 99 is not good enough. I'm gonna get my colonoscopy in a few
99 and a half won't do. That's it.
Just in case I can make it.
Well, I mean, we've talked a lot about colonoscopy, and I think it's important to focus on the fact that having bad colon cancer disease like most cancers that spread, it's not fun.
No.
You know, we try, certainly I try, obviously, I try to make sure that things are presented in a way that is light and is easily digestible. But when after you've been a doctor for like 3 seconds, you walk into some room where somebody is having a really bad period of whatever it is that's getting them. And any sort of cancer that has spread, it's not something you want. So I think if we are able to encourage folks to get their screenings, to get early intervention, to follow, as Dr. Maxey made the very important point, to follow the doctor's orders after you have whatever procedure you have. It matters a lot that you try to be that person that's 111 years old that just slips away in their sleep and just, you know, I forgot my blood pressure medicine this morning. That's the only pill I take, and I just slipped away one night. You know, we all want to be that person, but when you're not, it's not fun.
Very good. Let's have our final comments starting with Dr. Lawson.
Yeah, I just want to again emphasize this relationship between mental health issues and physical illness. That is, that colon cancer is one of those that there seems to be an integrated relationship with it, and that seems to be more common in people in a number of different chronic mental disorders. Also, and I think the most important point is, and I just want to emphasize it again, this fear of procedures, especially those that seem to be relatively invasive. Anything that looks like rectal exam or etc., people tend to avoid sometimes very emphatically. And I've seen physicians beaten up in trying to do these exams. That's the other advantage of anesthesia, by the way. So again, these procedures are life-saving and important and should not be delayed. And as usual, and I'm surprised my colleagues didn't mention that, look at the lifespan of African American men, and there's still that huge 5 to 10 year gap. And it's not because we are more susceptible to disease, it's because we do not get the early diagnostic and screening procedures and routine care that can be necessary for survival. If we get them, if we can get past those early years, life expectancy of African American men, like everybody else, and sometimes a lot of us go on 90, 100 years old. A lot of these recommendations, I've seen a number of providers who do not screen for African American men, do not recommend it because they don't think that we're going to live that long. Of course, if you use that reason, we shouldn't take Social Security either because we don't live that long. But the important thing is get these procedures done. It doesn't matter if you are African American, Asian, or what have you. There's a good possibility that we can detect something that will lengthen your lifespan and let you live a positive quality of life in terms of your later years.
Thank you. Dr. Hines?
We talked a lot about, as well as Dr. Lawson did, about some of the fears and the reasons why people don't want to have colonoscopies. And I would just encourage you, if you are on that list of people who are afraid to have one, be willing to discuss what your concerns are, right? Because sometimes if you're only willing to just say no, right, you may not be able to find out that some of the things that you are concerned about are applicable to you, and some of them may not even be applicable to you and your circumstance. And then I would also say colonoscopy is the gold standard, meaning it's the best option for screening. It's not the only option. So if you're in a place where you are recommended to get a colonoscopy for whatever reason, but you are just not there yet, we talked about the other options that are available. Something is better than nothing. So while you are working up, to getting there, just do something, right? Do the best that you can do as far as getting your colon cancer screening.
Thank you very much. Dr. Walks?
Thank you, Dr. Maxey. I have to say, just for the record, that I did take statistics in college and I got an A. Now, having said that, I say frequently, statistics have zero value for the individual. Statistics are population measurements. So when people tell you about what the statistics say about what you can do and shouldn't do, miss me with that. You talk to your routine practitioner about your situation, your family history, your personal history, and what's best for you. If according to statistics, when you look at your screen right now and you see Dr. Maxey and Dr. Lawson, there should be blank boxes right there. Neither one of them ought to be here. And I ought to be just checking into the hospital. So understand that when you read a lot of these things about statistics, they may not have anything to do with you. And the last question in the chat was about, if you're 90 years old, should you get cancer treatment? You know what? When I was a resident, we had a gentleman that I was part of his treatment team. He was 95 years old. He had stomach cancer, he had a gastric cancer, and the doctors decided they would go in and remove his cancer. He was 95. And he did well after that. The one caveat is, the older you get, the harder it is. And Dr. Hines mentioned this earlier, that anesthesia, you don't just wake right up all the time. It took him like a month to stop being, the appropriate medical term is goofy. He was kind of goofy for about a month after he got back up from the anesthesia. But once that time went by, he was having a very robust life, back to eating his foods. So don't let people tell you that you're too old or you're too black to get anything. Talk with your practitioner, understand what your risks are, and don't let somebody rob you of the next 10 or 15 years you have to play with your grandkids or work on your legacy in the nonprofit that you started, or whatever it is that you want to do between 85 and 105, because somebody told you that, well, statistically speaking. No, I understand statistics, I think, and I also know that individuals need individual assessments and individual interventions.
Thank you, Dr. Walks. Dr. Neighbor Stevens?
So I'm glad you went that direction, Dr. Walks, because I wanted to make two things that one of which I frequently bring up around holidays. If your family is planning a get together in the next week or so, or even later in the summer, take advantage of that opportunity to find out what's been going on in the past and in the present with your family members. And what if your family decides that they're going to have a cookout this year? I just want to alert you that not only should we be concerned about the mosquito-borne diseases that are increasing in frequency and Lyme disease coming from the tick bites, but there has been a report of increased incidence of a tick bite that transfers a virus that causes a syndrome called alpha gap. And that's not something that you want to play around with. It is the ticks are getting it from deer. And we know that deer are becoming increasingly more frequently carriers of pathogens. This alpha gap, the reason I wanted to bring it up, we've been talking about red meat and stuff. If you get bit by this infected tick, you develop a syndrome where you are allergic to red meat. And you can go into severe anaphylaxis, a severe allergy reaction, choking and not breathing, bad reaction. If you get bit by the tick and develop this particular syndrome. So
Where do
be
you get the tick from?
careful.
What kind of
Mhm.
place do the tick? Where do you get these ticks from?
They're
What's
all over the place now. You know, they used to like to say, oh, it's in the Northeast. Oh, it's in the Southeast. It's everywhere.
Okay, but more in rural areas or urban areas? Does it matter?
But the ticks go wherever the deer are. Now, if you go where the ticks are, that's how you get bit.
Okay. All right. Well, in my final comment, I want to say that it's interesting that for the past 6 months or so, maybe more, we've dealt with issues of diet, nutrition, not eating processed food, having exercise, etc. So there's something to it. Every single thing that we've talked about in terms of pathology is better for us when you eat right, exercise right, take care of your body, and take care of your health and your environment. And I want to congratulate Dr. David Stevens from talking about something that we read about before of how eating certain things are bad for you. And we know ticks are bad. We know that raw food, for the most part, is, even though I like sushi, is not necessarily good for you. There are such things as parasites. I don't know about people who eat bison, but anyway, if food should be appropriately cooked, and if you're celebrating this weekend, the 4th of July, which Frederick Douglass has his own thoughts about, barbecue, but well cook your meat and be careful what you eat, exercise and have fun. Enjoy yourself very much. Watch out for the danger of fireworks. Have a great day, everyone. Have a great Sunday. Thank you, my co-moderators. Thank you very much. Thank you, Simon.
Bye.
Good day, everyone.